During the President's State of the Union address back in, I believe it was 2003, when PEPFAR, or the President's Emergency Plan for AIDS Relief, was introduced, the program really saw this as an opportunity to move beyond research or give back to the communities that were participating in our research, the individuals. We started our program by going through and evaluating a lot of organizations that were already working in the communities where we were conducting our research. So identifying most of the public health facilities or hospitals were ones that we were already using, and there were set and established structures. But also looking at some community-based groups or faith-based organizations that would complement a facility-based service by following patients up at home, or working with community members on aspects of sort of improving their basic livelihood at the home level, including individuals who work with orphans and vulnerable children. Through our vaccine research development efforts, which in these communities actually predate our PEPFAR activities, we've developed a very strong laboratory capacity in order to support our vaccine research. And what we've really been able to do is use that laboratory research or that laboratory capacity to develop the capacity of our local PEPFAR partners, the facilities and hospitals, where patients who are on very complex therapies need to be monitored closely on a laboratory level, so chemistries, hematologies, CD4, to ensure that their therapy is effective, that they are able to maximize the benefits of the therapy that they're on. Our technical exchange has really focused on sort of the clinical aspects of the services, developing of labs, the establishment of quality assurance, quality improvement measures that, once you learn those skills, can transcend us still being there, but in addition to that, it transcends just HIV services to something that they could apply to their general medical clinic, their TB infection ward, their pediatric ward. So it's trying to develop sort of an overall aspect of quality improvement and capacity of our organizations. One of the first groups that I met was the Live with Hope Center. Their focus when we first met them was to provide some kind of home-based services, and a lot of it was grief counseling, a lot of it was holding hands and providing some management of pain and symptoms through basic analgesics and provision of food, and just being there and holding hands. And I think they also, when we looked at them at describing what their budget should be for the year, they had a rather large budget for funeral expenses. So building upon those activities that they were already doing, but looking at now, instead of holding hands until the person died, helping the person live longer and live a healthy life. Each year I go back to these sites, and at least once a year, and I've developed personal relationships with a lot of these individuals and even some of the clients. So it's nice to sort of see how they've evolved and how they've improved, and what kind of impact we've had on their lives. 2 years after we had started our program with Live with Hope, I was sitting there during one of their support group meetings with the adults. All of a sudden I got very emotional during the course of the testimonies, and I started to cry. And I asked Sister Placida to explain to them that it wasn't that I was upset, but that I was so happy to see how well they were doing, and that, to see the type of positive impact that our program has had on their lives, and that it really validates what we do.